for accepting for this workshop and this conference. So this morning we have two main part. One, Dr. Sanjeev will present about a single fiber EMG, and the second part we talk about the EMG basic analysis. So I think we can start now. And yes, Dr. Sanjeev, please.
Thank you. Good morning. Happy to be back in Vietnam after COVID. I always enjoy coming to different places. This is my first time in Da Nang, and it's beautiful beach, wonderful. So maybe this is where I should do my summer vacation. So, English is a foreign language for you and for me. So if I'm going too fast, ask me to slow down. Okay? Feel free to ask questions anytime. Okay? This is a very new method. So sometimes if you don't get your questions answered, then it's difficult to follow what happens later. So I will discuss single fiber EMG. And I have a surprise. I have brought with me two guest speakers. You will see them soon. Okay. Single fiber EMG was developed by Professor Erik Ståhlberg and Professor Jan Eksted. They were students of pharmacology, and they were interested in muscle fatigue. And as a result, they wanted to measure the propagation velocity in the muscle fiber, wanted to see how it changes because of fatigue. And that's why they developed single fiber electrode. And as they were doing studies, they realized that this can be used to study neuromuscular transmission. So that's the beginning of single fiber EMG. It did not start for neuromuscular transmission. It started for something completely different. And so Professor Ståhlberg wrote his thesis. His thesis is propagation velocity of action potentials in muscle fibers in situ. Okay? So this is Professor Erik Ståhlberg. Professor Eksted continued with other things. He did not stay with EMG. He's also done a lot of work. So single fiber EMG, what are the things that we are measuring? We always talk about jitter, which measures the efficacy of neuromuscular transmission. It is more sensitive than repetitive nerve stimulation. The second parameter that we don't typically talk about is called fiber density. Fiber density is very sensitive to study the muscle type grouping. Fiber density measurement is done volitionally. So you ask the patient to contract the muscle and you perform the recording. Jitter analysis can be done by volitional activity or by using electrical stimulation. Okay? So two different measurements, very different recording techniques. Single fiber EMG is also used in research. For example, it has been used to study the H reflex or blink reflex, to study whether it is a monosynaptic reflex, oligosynaptic, or polysynaptic reflex, etc. And single fiber EMG also led to the development of a technique called macro EMG. And I will discuss very briefly what is macro EMG. So let's start with some basics. We will start with a true single fiber electrode and then move our discussion into using concentric needle. Okay. So a single fiber needle consists of a 25 micron diameter wire, platinum wire, and it is exposed in the side port of this cannula. This is the bevel of the cannula. You will notice that the recording surface is on the opposite side of the bevel. Very different from concentric needle, where your recording surface is in the bevel itself. Okay. It is roughly 4 millimeters from the tip. So it's not at the tip, it's 4 millimeters behind. You always need two recording surfaces in EMG. We call it active, reference, and we obviously need the ground. So the small recording surface is your active. So this is your active recording surface, and the cannula behaves as your reference. So everything is built into the needle. Okay. We use different settings when we perform single fiber EMG. So first of all, we use something called amplitude trigger and delay. This is something that can also be used in needle EMG program. This is used to capture electrical activity from a single motor unit. And this is where you will be able to see a cross over here. So anytime the amplitude exceeds that horizontal level, we will capture the signal. Our filter settings are 500 Hz for high pass and 10 kilohertz for low pass. In our normal EMG, our high pass setting is about 10 or 20 Hz. So our bandwidth is much less. This is useful to exclude activity from distant motor units. Okay. We change our gain setting from 100 to 1000 microvolts, depending upon the signal amplitude. These signals do have high amplitude because you are using a very small recording surface. So although you are recording from a single muscle fiber, your amplitude can be as much as 3-4 millivolts. Okay. And finally, our time base, we adjust it 0.5 to 2 millisecond per division. In our routine EMG, the time base is 10 millisecond per division. So essentially, we are expanding the sweep so we can see the potentials better. Okay? So let's look at this example. You can see the gain over here, the time base. This is the potential, and let's listen to it. Here is our trigger. Listen to the sharp, crisp sound. Okay. It has a roughly biphasic or triphasic waveform. You see, this is phase 1, phase 2. It is biphasic or triphasic. It has a very short duration, maybe about 1 to 2 milliseconds. This is important to know when we perform the recordings. That way we can differentiate what is a true single fiber potential versus something else. Okay. So that's the way the single fiber potential looks like. A biphasic or triphasic waveform with amplitude of 200 to even 2000 microvolts and a short duration, about 2 milliseconds. Okay? It looks very different from a motor unit potential. So that's a summary of the waveform. And another important parameter that we look at is the rise time, which is the time it takes to go from the positive peak to negative peak. When you are very close to a muscle fiber, the rise time of a single muscle fiber action potential is less than 300 microseconds. Okay? So that's what we are going to look for when we make our recordings. Any question on the basic single fiber potential? Okay. So let's look at what did we call the recording territory of the single fiber electrode. This is a classic slide. This was a special experiment. I think this was a mouse muscle where they stimulated one axon for a very, very long time. As a result, the muscle fibers were depleted of glycogen. So after stimulation, they sacrificed the animal and stained the muscle for glycogen. So now you can see muscle fibers of a single motor unit. See, they are not clustered together. Before single fiber EMG, we used to think that fibers of a motor unit are in a cluster, like a cluster of 20 fibers here, a cluster of 20. And that is what was called a subunit. With single fiber EMG, we realized that the muscle fibers are distributed over a much larger territory. Okay? And they do not have a tendency to form groups. So that was a major change in our understanding of motor units from single fiber EMG. Next, all electrical fields, when we record them, they decrease in amplitude. Okay? If I am speaking without the microphone, person on the first table will hear me loudly. Somebody in the back, it will be very faint. This is natural. Single fiber potential also decreases in amplitude as you go away from the fiber. And what we found out based upon recordings is that if you are more than 300 microns away, see, that's a semicircle with 300 micron radius. If a fiber is more than 300 microns away, then the action potential amplitude is very small, less than 200 microvolts. If a muscle fiber is inside 300 microns, then it has an amplitude more than 200 microvolts and a rise time less than 300 microsecond. So now, by looking at action potentials, we can find out how many of them are close to the needle tip. Okay? So that's what is done when we do fiber density measurements. So we place the electrode close to a muscle fiber and we count the time-locked action potentials. 1, 2, or whatever. Okay? So let's look at the technique of doing fiber density. So here is our first guest speaker. This is Professor Donald Sanders from Duke University. He did a lot of work on myasthenia. He used single fiber EMG. So let's look at how do you do single fiber EMG in the EDC muscle. Okay.
The electrode is inserted into the muscle while the patient slightly activates the muscle. The electrode is positioned close to a single muscle fiber. And we know.
So again, look at the angle of the needle. Concentric needle, we usually go like this. In single fiber, we go at an angle because you are recording from a very small area. If your needle slips just a little bit, you will lose the response. But if the needle comes like this, even if you change a little bit, you will still be next to the muscle fiber. Okay? So again, from here, if the needle slips, this is a fiber, this is a needle. If it slips, you are away from it. But if you go like this, see, now you are closer to the muscle fiber much longer. This is something really important because you have to change your approach when you do single fiber. Single fiber EMG takes a long time. So you don't hold the needle like this. You always rest your hand like this on the patient. Or if you are doing it in the face, you rest your hand on the patient's head. That way you can hold the needle steady for sufficient time. Okay? So that's the important thing. You hold the needle like a pen, but you insert it at an angle. And there are two things that you are going to do. You either move the needle in or out, or you rotate it like this, okay? Because then it will change the position of your active electrode in different directions. So when you look at this video, notice how his fingers are moving. The needle is going this way, and you will also notice a rotation of the needle. Okay? At the bottom, you are going to see the action potentials, and we are trying to maximize the amplitude and count the number of fibers. Okay? Any questions on this basic practical approach? Okay, so let's listen to Professor Sanders.
Know it's close when we see a sharp, clear spike that doesn't get any larger when we very slightly manipulate the position. So we optimize the recording position of the electrode so that we get a maximum amplitude single spike.
So in fiber density, it is important that you maximize the amplitude of the potential. Okay? Even if you see a nice spike, you don't stop there. You adjust the position to get maximum amplitude. Only when you have got maximum amplitude, then you start making your measurements. Okay? So in this case, that's a single action potential.
At that point, we look to see whether there are any other spikes time-locked to that triggering spike.
So that's a single.
Not, then we record this recording position as having a fiber density of 1. We then move to another site selected the same way. And if there are 2 spikes, we record.
Do you see? Now there are 2 spikes. And again, it is important to see that they are time locked. If they are time locked, they always occur together. That means they have common innervation. If you have got multiple motor units discharging, then their potentials are not time locked. Okay? So having time locked potential is critical in single fiber. So in this case, we call it 2 action potentials. And again, we look at the number of potentials with a rise time less than 300 microseconds and an amplitude greater than 200 microvolt. That means the fiber is within 300 microns. Okay? So this is the way we do it at 20 different positions. We go to position 1, maximize amplitude, count how many potentials we have. Then we go to another position and a third position, and we do this 20 times. So here are examples. Let's count the fibers. 1, 2. So there are only 2 fibers that are time locked. They fulfill the criteria of amplitude and rise time. So on a piece of paper, we will say fiber density is 2. Local fiber density at that site. Sometimes we may see like this. Now you can see 1, 2, 3, 4, 5, and maybe there is a small fiber over here. So in this case, we will record the fiber density as 6. Okay. So earlier I showed you the cross section. Most often, when you position your needle, you will see only one fiber, okay, in normal muscle. In about 40% of the places, you may see 2 fibers, okay. So in most normal muscles, you see 1 or 2 time-locked action potentials. You do this 20 times, and then you take the average value, which is your fiber density. So let's go back into our previous recording. If typically we see only 2 fibers, why do I have 6 fibers? That is because of reinnervation. Because a motor unit died, we had denervated muscle fibers, and then we get reinnervation. So within that circular 300 micron, instead of 1 fiber, now you have 1, 2, 3, 4, 5, 6 because of reinnervation. So in this way, fiber density is the most sensitive method to investigate reinnervation. Okay? It is more sensitive than fiber type grouping assessment on muscle biopsy. Okay? Typical fiber density values are like 1.6 or less. On muscle biopsy, you will find evidence of reinnervation when fiber density is about 2.5 or 2.6. So this is the way fiber density can be useful to study reinnervation. And long time ago, we used fiber density as a criterion in the diagnosis of ALS. You wanted to show reinnervation, and increased fiber density was one method of doing so. Okay. Fiber density varies in normal muscles. Again, here is an illustration from Professor Sanders. And there are some muscles with high fiber density going up to 1.6 or 1.7, as I indicated. Some muscles, most often you get only 1 fiber or so. Fiber density also changes with age. So you can see on the x-axis, we have the age, and on the y-axis, we have fiber density from many control subjects. And you can see fiber density is higher in older subjects. And again, this is natural because as we get old, we lose motor units, and therefore there is some reinnervation. Okay? What that tells you is that if you got higher fiber density and you want to learn jitter analysis where you want to get 2 or 3 spikes, you should use older subjects for learning the technique. Don't try young people with myasthenia. Start by doing tibialis anterior in patients with, say, diabetic polyneuropathy. Then you can easily get 2, 3, 4 time-locked spikes for jitter analysis. Okay. And again, this is the effect of age, and you can see the tibialis anterior has a profound change in fiber density compared to other muscles. So that's the muscle that we recommend for learning single fiber EMG. Okay. Any questions on fiber density? Okay. Keep in mind, fiber density can be done by using a single fiber electrode only. You cannot use a concentric needle because it is based upon how fast the amplitude decreases. Okay. Now we go to the other measurement, which is neuromuscular transmission, jitter analysis. So I want to review a little bit of basic neuromuscular transmission before we start investigating jitter. So we all know a motor unit consists of all muscle fibers that are innervated by one motor neuron. When the motor neuron discharges, all muscle fibers respond by producing action potentials that we record as EMG, and we get a muscle twitch. And in order to maintain a steady contraction, a motor unit discharges in a continuous manner. Okay. Let's look at the neuromuscular transmission. So here you can see our myelinated axon over here. Then you have its terminal, which is called the buton. So this is the buton. This is the muscle fiber. This is the nerve terminal. And in between, you have the synaptic cleft. If you look at the muscle fiber membrane in the synaptic cleft, it is not like a straight thing. It has got a lot of folds. Those are called the junctional folds. Okay. This is where the neuromuscular transmission occurs. Those are called the active zones in the neuromuscular junction. Let's look at more detail. So here is one such terminal over here. You can see the nerve membrane. This is the muscle membrane. This is the synaptic cleft. And this is your active zone. On the side of the active zone, we have the synaptic vesicles. Think about it like a football game. So this is your field in between, and here are players and here are players. But they don't go in the field until the game starts. So this is the synaptic cleft. On the muscle side, at the top, you have the acetylcholine receptors. And at the bottom, you have the sodium channels. That's roughly the organization of the buton or the neuromuscular junction. So how does the neuromuscular transmission occur? It starts by the arrival of nerve action potential. And when the nerve action potential comes into the buton, calcium is transported from extracellular space to inside. Calcium is necessary for mobilizing these vesicles to the field over here. So now some acetylcholine vesicles came into the field, and by exocytosis, they are released in the synaptic cleft. Okay? So the nerve action potential arrives, calcium comes in, acetylcholine comes into the active zone, released. Now, when you release something, there is a high concentration of acetylcholine over here. It is going to start diffusing to the postsynaptic membrane. Anything that is in high concentration always moves away. So if I were to open a bottle of perfume, after a few minutes, you will be able to smell it because it diffuses. So as the diffusion begins and it starts coming close to the postsynaptic terminal, we also have acetylcholine esterase. And the job of acetylcholine esterase is to remove acetylcholine. So it takes it away, converts it into choline, and sends it back for resynthesis. So we have a race. Acetylcholine is trying to reach the postsynaptic terminal, and esterase is preventing it. There's a balance between them. Okay? Some of the acetylcholine will reach the receptors. And when it reaches the receptors, it's going to open sodium channels. Sodium flows into the membrane, and that begins the so-called end plate potential. So this is our resting membrane potential, and we get a small depolarization. This is the end plate potential. And when the end plate potential reaches a critical threshold, you get a full-blown action potential. And this will propagate from the neuromuscular junction to both sides to the tendon. Okay? So that's how a muscle fiber action potential starts after an incoming nerve action potential. Now we are back into the process of recovery. So the nerve terminal repolarizes, calcium goes out. Calcium typically stays in the buton for about 200 milliseconds. Okay? Why is that important to remember? Because if you stimulate at interval less than 200 milliseconds, calcium will start accumulating and it will improve neuromuscular transmission. So that's why in repetitive nerve stimulation, we keep our stimulus rate to less than 5 Hz. Okay. Acetylcholine will get replenished, and any muscle fiber membrane will repolarize, and now you are ready for another nerve action potential. So let's look at the end plate potential. This is a recording from an end plate in a patient with myasthenia. Again, this was provided to me by Professor Sanders. So this is very much like a nerve conduction study. We are stimulating the axon and we are recording the potential inside the end plate. This is not outside. This is inside the end plate. Okay. So you can see there is a little bit of stimulus artifact, nerve propagation, and then you get this response. It looks like decrement on repetitive nerve stimulation, but this is actually a single end plate potential. Okay? And when you stimulate repeatedly, you will notice that the amplitude goes down. Now, this happens even in a normal end plate. Okay? And that is related to how much acetylcholine. Let me just adjust this. This is coming in my face and I cannot see it. Okay, this is more convenient to look at you. Okay, so you can see there is a decline in the amplitude, and that's because of reduced quantity of the vesicles. You see it in the first force stimulation, and then the vesicles get replenished. So that's why it kind of becomes steady. So this is what is called the rundown phenomenon. When you stimulate the first time, this is your end plate potential. Second time, third, fourth, it kind of reaches minimum, and then it kind of relieves, stays at the same level. This is the level that is required to produce an action potential. So when the end plate potential is higher than this, it will produce an action potential. So every time you stimulate the axon, you get an action potential. Okay? This is normal physiology. So even though there is rundown, you do not see it on extracellular recordings. And the ratio of the threshold to the end plate amplitude is called the safety factor. It's about 2 to 4. Now in pathology, you do get the rundown, but now the end plate amplitude is less than the threshold, and therefore you do not get any action potential. And if you do not get any action potential, in repetitive nerve stimulation, you will get decrement. So that's the basis of decrement in repetitive nerve stimulation. Now let's see how it relates to single fiber. But before that, let's look at an example of decrement in myasthenia.
That is the study on the left, AD2, 3 per second stimulation, 9 shots.
And you can see how the amplitude decreased over here.
Decrement is approximately 45%.
Okay. So this is your end plate potential. This is where we stimulate. This is nerve conduction. This is the end plate potential over here. And then this is the action potential, just for your reference. So on the top trace, when we stimulate, we get a very nice action potential from the muscle fiber. Next time you stimulate, you develop the end plate potential, but it does not reach the threshold. And therefore, it just comes back to the baseline. We do not get any action potential. And the same thing happens on the third. So this is the basis for normal response versus decrementing response. But if you look carefully, you will notice that if you continue to stimulate, you do get action potential, but it varies in time. Sometimes it comes early, sometimes it comes late. So the action potential does occur, but at a different time. So if the action potential occurs, our compound muscle action potential will be normal because the action potentials are there. There will not be any decrement. But when we look with a needle, or if we look at this phenomenon, this shows that the time variability among the action potentials is now increased. And that's the basis for jitter. Okay? So what we are looking at is how does the time between two muscle fiber action potentials changes on successive discharges. You follow the concept of jitter? It's a variation in time that we are going to quantify. Okay. So the same thing is shown over here. This is our threshold for generating an action potential. Here are the end plate potentials that blocked. This is where they produce an action potential, but there is a great variability in time. So there is jitter in all muscles. It is low in healthy subjects and it's increased in patients. Okay? So that's the reason when you have increased jitter, but it is not large enough for the action potential to block, single fiber EMG would be most sensitive to demonstrate abnormal neuromuscular transmission. If you are getting block, if you are getting big decrement, 20%, 30%, your jitter analysis is going to be, has to be abnormal. Okay? So in that case, you don't have to do single fiber. But if you do find that the patient maybe has ptosis, maybe has weakness, but repetitive nerve stimulation is still normal, and you strongly believe the patient may have a primary neuromuscular junction disease, that's when you use single fiber. Okay? So now let's look at the volitional method of jitter analysis. So once again, we are looking at the technique over here. We have the needle, we have the ground electrode, and so on and so forth. Now the technique is different between fiber density and jitter analysis. In fiber density, you have to position your electrode to maximize the amplitude of one potential because you want to be next to it. That is not the case in jitter analysis. In jitter analysis, you would like to be somewhere in the middle of the two fibers so that you can record both action potentials for measuring jitter. Okay? So once again, this is in the cross section. If you are doing fiber density, you place the electrode over here, you maximize the amplitude. Fiber density is 1. To do the jitter, we try to position it between the two electrodes. So we'll notice that this was the fire potential from this. As we moved the electrode over here, it became bigger. And the potential from this one, which is over here, became smaller. The idea is that you need to get two decent potentials. They don't have to be maximum, but so long as they are sharp, they have a short duration, fast rise time, that's okay. Okay? So keep that in mind. That's why we never do fiber density and jitter at the same time. We do the jitter study, then we will do fiber density. Because otherwise, if you are doing jitter, you will start over-counting fiber density because you are always going to have two fibers. Okay? So let's look at single fiber EMG with voluntary activation.
Measurements can be made in many muscles in the body. The facial muscles are particularly useful in assessing myasthenia gravis. We're going to do jitter measurements through voluntary activation in the frontalis muscle. This is a particularly useful muscle because it's frequently abnormal in myasthenia. It's an easy muscle to identify and to make recordings from. And it's an easy muscle for the patient to activate at varying levels. All the patient needs to do is to open the eyes.
Okay, so frontalis is an important muscle because when you get ptosis and other things, that's the muscle you're going to investigate. Typically, we look at frontalis. Some people look at orbicularis oculi. Either muscle is fine. Okay. Again, what I'm trying to demonstrate over here is the technique. How do you activate the muscle? How do you control the activation? Okay.
And look up to a varying degree. We'll start by looking at the lateral portion of the frontalis.
So with frontalis, we have the lateral portion, we have the medial portion. We like to investigate both. Okay?
This is a very thin muscle and therefore needs to be approached with the needle electrode variably.
So once again, look at the needle. I mean, you cannot go into frontalis over here. You cannot go perpendicular. You have to go sideways. This is your amplitude trigger and delay line. We are 1 millisecond per division, 100 microvolt per division. So if you look at it, it's 100 microvolts, and our amplitude over here is 100 microvolts. So that's not a good position if you are going to do single fiber, okay? So you need to have good amplitude. So we try to adjust the needle position.
We will adjust the electrode to maximize its amplitude.
So now you can see this amplitude, this is 200 microvolts per division. This is about 8 or 9 divisions. So the amplitude is like 1800 microvolts. It's a very high amplitude signal. 1 millisecond per division, if you look at the duration, it's about 1.5 milliseconds. It has a very sharp rising edge. That's the way single fiber potentials look like. And that's the kind of potentials we like to use for analysis. We change the gain. So that's a single. We cannot measure jitter in this. You need 2 time lock potentials. So now he's rotating the needle. So when you rotate the needle again, you can bring it close to a muscle fiber. Again, that's good amplitude, 1 millivolt. So now we are in the medial portion of the muscle.
The subject is looking upwards to maintain a steady contraction of the muscle. And at this site, many different single muscle fiber action potentials can be seen.
So if you see there are many potentials that are coming, you ask the patient to relax, okay? The trick in single fiber EMG is to advance the needle to get to the active muscle fiber. Not the other way. You don't just tell patient, give me more force, because that's going to make a bad recording. So you look at a small potential that is going in the baseline and then try to move the needle towards it or away from it or rotate it. Don't ask the patient to give more contraction, okay? So you want very slight contraction. The other thing that we do is, in order to help patient activate in our labs, we often have spots on the ceiling. So we say, look at the red dot, look at the green dot, look at the black dot, because now they can see up and down, and you just stay focused on it. That way, you get a steady contraction. Or you can tell them, look at 9 o'clock, 12 o'clock, 11 o'clock. So these are some simple tricks that you can use for coaching the patient. Okay.
Even in normal muscle, the frontalis fiber density is high enough that we can usually find has a potential without a lot of difficulty.
So this is all single. Now there are 2 potentials very close to each other. You can trigger below the baseline or above the baseline. And you see this waveform keeps changing. It's like a broad spike and then all of a sudden it splits. That is what increased jitter looks like. Because when the jitter is normal, everything looks almost exactly the same place. When the second potential starts moving, that is increased jitter. So that's our visual assessment. See, this is normal. Again, let's look at, okay. And now we go to another site and so forth. You can hear a distant potential.
The Hoang interval produces a rather hollow sound with a bit of an echo.
See, now we have three potentials.
We have a thermal potential here, we're figuring on the second slide.
So now I'm going to introduce some concepts. The time interval between the two potentials is called the interpotential interval. Okay? So in this case, we can have an interpotential interval between 1 and 2, 2 and 3, 1 and 3, depending upon what we want to analyze. Usually, when the interpotential interval is more than 4 milliseconds, you may get high jitter because of something called velocity recovery function. I will not go into the details. Just remember that if you are getting high jitter and the interpotential interval is more than 4 milliseconds, we don't accept it. But if it is normal, then I keep it. Okay?
Using their potentials with normal jitter, retreating below the baseline, and the rising.
See, this is one motor, and you can see in the background there are other signals. They are not time locked because they were from other motor units. Okay? So, once again, so now that we have seen how the signal should be, this is how we typically do jitter analysis. We trigger on one action potential, and you see the second action potential is jumping to left and right. That's the variability that we are trying to measure, and that's jitter. Okay? So 2 or more time lock potential, they should have parallel rising edge. That means from one discharge to next, the rising edge should stay like this. It should not go like this. Okay? That's tilting. And that will occur when your needle position changes. Okay? So parallel, on all discharges, the rising edge should stay the same. And we like to record 100 such discharges. Okay. Then we measure the time interval between potential 1 and potential 2. That is your interpotential interval. So on the first discharge, let's say this was 950 microseconds. On the next discharge, it was 995. On the third one, it is 940. On the fourth one, 960, and so forth. We take the difference between consecutive interpotential interval and we ignore the sign. Okay? So 950 and 995, the difference is 45. 995 and 940, the difference is 55. So we calculate these differences and take the average value. This is called mean consecutive difference, or MCD. So when we talk about how much was the jitter, it usually refers to this calculation called MCD. There is another formula which is called mean sorted difference. Let's not get into the details of that. There are two formulae. Whichever one gives you the lowest jitter, that's what we accept for analysis. Okay? And this is what Long time ago, we used to do it manually from printouts. Now the machine does it for you automatically. So as I indicated, jitter is present in all muscles. In healthy subjects, the jitter is low. So let's start with no normal jitter. In this case, 10 microsecond. Listen to the sound. It's a very static sound. Doesn't change. If you superimpose the traces, you get very good superimposition. So that's an indication of low normal jitter. Now look at the superimposition and the sound. It keeps changing. You can see the potential also jump. So this is slightly higher jitter compared to the previous recording. And the jitter was 38 microseconds. Okay? And when you superimpose, you can see it doesn't superimpose as well as the previous recording. Now this is abnormal jitter, increased jitter. Typically, normal muscles have jitter less than 55 to 60 microsecond. It does vary, but remember 60 as a kind of a number if you are not sure about the reference value. Look at the potential over here. See how it varies to the left and right? So superimposing the traces gives you the best appreciation of jitter. Okay. So this potential has got increased jitter, but it always comes there. Okay, sometimes it is late, sometimes early, but it's always there. And now look at this one. One potential, and the second one comes and goes. This is increased jitter and blocking. So sometimes the second end plate was failing. So here is the nerve fiber, and these are the two end plates over here. The nerve action potential came. It was always transferred on this fiber, but on this fiber it was failing. So sometimes you see two potentials, and sometimes you see only one. So you understand the concepts. There is a normal jitter, increased jitter with blocking. Any questions on these three concepts? Okay. Blocking is something we suggest the operator should check and make sure. So you can raster your traces. You can always see the first potential. Here is the second potential. It is missing over here. And when it is missing over here, we look at the waveform of the first potential to make sure it hasn't changed. Okay. Increased blocking will typically occur when jitter is more than 100 microseconds. Most often, okay? So if you start seeing blocking with normal jitter, there is something wrong. It's a technical problem. Blocking is not seen when jitter is normal. Because what will happen is when you start doing jitter analysis, the machine will make a lot of calculations. And sometimes if there are problems with the signal, it will say jitter is normal, but there is blocking. That cannot be right. So the user has to take control of your analysis. Okay. So one of the things that is most useful in jitter analysis is something called the sequential interpotential interval histogram. So as you are recording the EMG activity, you make a plot of interpotential interval. So this variability is your jitter. When the jitter is normal, it doesn't go up. It stays kind of close. If the jitter is increased, now the data points will go up and down like this. So this is a very good tool to assess the quality of your recordings, the outliers, and other things. So this is something that we heavily rely upon in editing our data. Now, it is important to recognize that in a patient, you will have normal end plates, mildly affected end plates, and severely affected end plates. Again, this is from Professor Sanders. From one muscle, at one site, you can see the jitter is absolutely normal. At another site, the jitter is increased. And at a third site, the jitter is increased and there is blocking. What it means is that you need to sample the muscle extensively to find abnormalities of neuromuscular transmission. So a typical jitter study, we have 20 jitter values. So we go to site number 1, record a pair of action potentials, measure jitter. So at the first site, let's say it was 34. Then you go to another position, make second measurement. So you need to make a total of 20 jitter values. And then there are two ways of analyzing this data. One is based upon the mean value of jitter. So you can see that over here, the mean jitter in this case was 31 microseconds. And then there are normal values for mean jitter. The second strategy is to look at individual recordings and see if it is normal or not. So for example, the upper limit of mean jitter may be 40. So if the average jitter from 20 pairs is less than 40, it's normal. Upper limit of individual recording can be 60. So if any recording is more than 60 microseconds, then we will call it abnormal, that one side. So here you can see there were 2 recordings that had increased jitter. The way we have defined our normal limits is that you are allowed to have 2 abnormal recordings out of 20. So you make 20 recordings. If 2 of them are abnormal, we still call it a normal muscle. Okay? Because there is always some kind of trauma or something that has happened we don't know. So we always allow some exceptions. By the same token, if you find 3 or more abnormal recordings, then the muscle is abnormal. So let's say you start with the first recording, normal, second, normal, third, abnormal, fourth, abnormal, fifth, normal, sixth, abnormal. I already got 3 abnormal. I can stop the study. Okay? Otherwise, you have to continue up to 20. If you are not getting abnormalities, or if you don't have more than 2 abnormal ones, then you continue to do up to 20 recordings and look at mean jitter. Okay. Reference limits, again, they depend upon muscle and age. So criteria for abnormal, either you have increased mean jitter or you have increased jitter at 3 or more sites. Okay. So that was the volitional method. Now let's look at the stimulation method. So this is something that we use when the patient is uncooperative. For example, baby. They are not going to give you constant activation. Or the patient has tremor and other things, which makes it difficult to get steady muscle contraction. The principle is that this is very much like nerve conduction study. we stimulate the nerve. So this is, we are using a monopolar needle for stimulation. This is the cathode. This is the anode. This is the single fiber needle. And now we are recording from orbicularis oculi muscle. Okay. So instead of having the junction activated volitionally, we are going to activate it by electrical stimulation. Okay. So here is Professor Stolberg explaining the technique.
We're going to show the stimulation with the surface electrode, and we're going to record from the frontalis muscle. First, it is rather convenient to find the place for the nerve, and we want to go as distal as possible, but not too distally so that we get.
Okay, so typically when you do the facial nerve stimulation, you stimulate somewhere over here, but that will activate the whole face. So that's why we stimulate as distally as possible. So the first thing we do is find out where is the nerve. So just using standard nerve conduction, you just stimulate the nerve and look for eye twitch. Okay.
Disturbances when we do the recording. I'm going to use a stimulation duration of 0.1 millisecond. And here I'm now increasing the stimulus. Now I feel it. And here I'm in a position where you can see small jerking. I increase it so it should be easy to see. And then I go a few millimeters away, and it is still jerking, and here is much less. And here it seems to be the maximum. And here it is very little again, and here is nothing. Here's the max.
So you try to find the position where the nerve is, because if you stimulate right there, your intensity is going to be far less. Okay. Again, in stimulation single fiber, we are going to stimulate at very low intensity. We are not doing supramaximal stimulation. Okay.
And I stop that test and will glue on some surface electrodes. I have now placed the stimulating electrodes here.
So some people use a monopolar needle for stimulation. You can also use surface electrode. Whichever way you want to do it, it's up to you.
The cathode is here and the anode here. I use still 0.1 millisecond duration, and we want to see the twitching here. And
you can see the twitch.
We have to use a little higher stimulation strength, and in this case, now you see I go down with the stimulus, and I still see the twitches quite clearly, and we are at the 5 milliamp. Probably we can go down further when we get the recording going. Relax in the face. Here, we're going now to increase the stimulus intensity, and we're using 10 Hertz.
Okay, so we are stimulating at 10 Hertz. This is our needle, and this is our stimulus artifact. Okay, and then this is where we are going to get the muscle fiber action potentials.
Same most common. Then we increase that to.
Look at the intensity is very low.
And we will soon get the response here. And here we can see how I'm going up and down with the stimulus, how these three spikes come and go together. And that means that they are from the same.
So what you do is you increase the intensity or till you get a spike. And just at the threshold of stimulation, sometimes you get the potential, sometimes you don't. That's called a subliminal stimulation. you need to increase the intensity above that, okay? So controlling the stimulus intensity is very important in single fiber EMG.
Excellent. This is now the position where we can...
So now it is stable, and now we record the jitter.
And if we increase the stimulus more, other fibers come in and are more or less disturbing to the picture.
See, this is not good.
Slides as possible. One trick is also not to be right in the center of the muscle, the more twitching part, but out in the side of the muscle, where it's more likely to be clean signals.
So let's look at some waveforms. See, if you look at number 2, it looks like it is blocking, because sometimes you see it. That is because the stimulus intensity was just threshold. And this is something that will happen in stimulation method. So you have to be very careful to make sure that you are stimulating the fiber adequately. Okay? So, stimulation method, it's a little tricky, okay? Earlier, I was at low intensity and it looked like blocking. When I increase the intensity, now both potentials come there together. Now, if you increase the intensity, you get more fibers. See, that's subliminal intensity. So at subliminal intensity, you can get a false impression of increased jitter and blocking. And that's one of the major pitfalls in stimulation single fiber EMG. Okay, so that was a quick introduction to our basic techniques and so forth. Everything that we did, let me stop this. Everything that we did was using a single fiber needle. So now let's talk more practical, because we are no longer allowed to reuse an electrode. Single fiber electrode, it used to be like $500. And we are not allowed to sterilize it. So the idea is that can we use a concentric needle for jitter analysis? So here are some of the issues. This is your single fiber electrode. It has a diameter of 25 microns, and it records from up to 300 microns away. This is a concentric needle. You can see it has a much larger recording surface. And if I were to place fibers, see, this electrode is already recording from 3 fibers. It really cannot record from a single fiber. So there are some things that we can do. We can perhaps reduce the size of this recording surface. So now we have a concentric needle with 0.02 millimeter square surface area. And now it is predominantly recording from this muscle fiber, but because of volume conduction, it could also record from here and here. We can further reduce the contribution from distant fibers by changing our high pass frequency setting. So the changes that we make is, this is the concentric needle that we use for quantitative jitter analysis. So these are also called facial concentric needle. Most people say, I use the red needle because it has a red hub over here. And we also use a 1 kilohertz high pass instead of 500 hertz. Jitter is measured between spikes because we are no longer recording from single fiber potentials. We have a larger recording surface. So we have to pay particular attention to the shape of the spike. Okay? And the normal values for jitter are different between concentric and single fiber electro. Keep in mind, we cannot do fiber density analysis using a concentric needle. So let's look at some of the quality. We like the amplitude to be more than 50 microvolts. We like to display the signal so that it is at least 1 division tall, so that you can see the baseline noise and other things. Parallel rising edge, there should be no tilt. There should be no shoulders. I will explain to you what a shoulder is shortly. So, look at this action potential. Parallel rising edge. We are at 200 microvolts per division, so this amplitude is 200. So that's good, more than 50. They have short duration, 500 microsecond per division, so just about 1 millisecond. So this is a good recording. This is also a good recording. The interpotential interval is short. This is borderline acceptable. We are at 50 microvolt per division. This is more than 50. This is just over 50. And it has got parallel rising edge. Okay. This is not acceptable. You see it rises and then it becomes flat. That is called a shoulder. So anytime you see something like this, you do not accept it for analysis. You can also see there is a wide change in the amplitude. This indicates interference from somewhere else. So this is not acceptable. Look at this. Here the shoulder is on the right side. But perhaps this is far away, so maybe I include this. But look at this rising edge. You know, it kind of comes over here and then it has a little bit of shoulder. So such recordings should not be accepted. This is too wide, 500 microseconds per division. This has a duration of 2 milliseconds or so. So this is a very, very composite signal. And here are the reference limits. So this is for the mean jitter, and this is for the individual jitter that I referred to. So again, let's look at some of the limitations. We cannot use it for fiber density. Stimulation technique is not efficient for large muscles. It's very difficult to get clean spikes. So the recommendation is not to do stimulation jitter in tibialis anterior, for example. You can use it for frontalis orbicularis oculi. That's okay. Practical, you adjust the needle, record 100 sweeps. You can do analysis, manual or automatic, using peak or level, and that's something that I will demonstrate. You select the action potentials, you remove the outliers, you remove the interfering traces, and make sure blocking is confirmed manually. Here is the most important thing. Increased jitter and blocking does not imply a primary neuromuscular junction disease. If you have denervation and then reinnervation, during reinnervation, you will have new end plates, and they will have poor neuromuscular transmission. So you will see increased jitter in blocking in radiculopathies, ALS, many conditions. Okay? But if you get normal jitter in a weak muscle, then you can say this is not myasthenia. Okay? The diagnostic sensitivity is greater than 95% when two muscles are studied. Always study a weak muscle. If you are getting decrement, nice 20-25%, jitter analysis is not necessary. But if the repetitive analysis is normal, and if you still suspect a primary neuromuscular junction disease, now single fiber EMG is a good technique. Keep in mind, single fiber cannot differentiate presynaptic and postsynaptic. So Lambert-Eaton and myasthenia they will look the same on jitter analysis. Keep in mind that blocking occurs when jitter is increased significantly. So if you are getting a report that shows normal jitter with blocking, that means there is a technical error. And you can stop recording when the third abnormal pair is found. You don't have to record 20 pairs to demonstrate abnormality. But to demonstrate normality, yes, then you want to get 20 pairs. Normal limits vary by age and muscle. Okay, if you are trying to learn how to do single fiber EMG, do it in patients with reinnervated muscles with neuropathy. So tibialis anterior in a diabetic polyneuropathy is a good muscle to start learning. Coach the patient to maintain slight force of contraction, then adjust the needle. Don't just stick the needle and tell the patient, okay, give me some signal. It doesn't work. Listen to the sound. Many times you will hear the jitter before you see the pair. And rotate the needle to optimize the signals. When you are beginning, allow sufficient time for analysis. Most systems will allow you to record the signals and do offline analysis. Okay? But we like to make sure that we have got good quality signals before we let the patient go. Okay? And do not be frustrated if you are not able to record a pair of jitter. Professor Stolberg, it took him several hours to get his first pair of recording. Now he can do everything in less than 15 minutes, but his very first recording, he was in the muscle for about 15, 20, 25 minutes. So if you are having difficulties, don't get frustrated. Okay? I skip macro EMG for the time being. Let's go through our demonstration part of it. You will find more information in the textbook, Single Fiber EMG. And Eric, Yoshe Trontels, and Don Sanders and we also created videos and other things. So these are two excellent resources. This is on the web. This is a textbook that you can use. So thank you. That's Eric. That's his wife. And that's me. I think we were in Dubai teaching a course at that time. So thank you very much. So what we thought we will do is actually do a demonstration of single fiber. Is that okay? Or okay. So give me 2 minutes because I will need to set it up, and then we will perform a recording. Okay? Sure. I want to show them first on myself, and then we do the patient because I don't want to torture too much the patient. Yeah. Okay. No, alcohol we don't need. We drink it. Okay. So tibialis anterior, you feel about 4 fingers over here and feel the muscle and you insert it. Okay. The next thing, we need to listen to the sound. Okay, so I'm going to turn on the sound. Okay, so now you can see over here. Here is one spike, Here is another spike. And the machine is trying to measure the time interval between the two. You see, this is the interpotential interval. That is your jitter, actually, how it is going up and down. Okay? So I'm going to stop recording over here, or maybe now I record for 100 or 150 discharges. Okay. So this is where my interpotential interval is very short. So this is, instead of level, you may want to use peak for analysis. See, this jitter is 51. This is normal. Okay. Let me see if I use peak for analysis and it becomes 41. So when the potentials are very close to each other, you may want to use peak for analysis. When the potentials are away from each other, then you can use peak or you can use level trigger. So,
sorry, if I may just
sure.
ask, yeah. So you can either use peak or onset in this case, right? So over here you use the onset.
No, I'm using the peak now.
Okay.
See, on the rising edge, I'm using the rising peak.
Okay.
Okay.
Rising peak.
So now let me try to go to the next recording over here. So now we can clearly see the two spikes. You can see the interpotential interval. And I'm going to stop over here. See, what happened was my needle moved and you saw the second potential go away. So many times change in the needle position will produce a trend like this. So no problems. What I'm going to do is, this is my sequential interval plot. I always focus on this one. So initially there were some things that were not nice. I just say, okay, this is where I started getting good data, and up to this portion, that was good. Okay, so selecting data is important. In old days, we would take one waveform, keep it, reject it, then the second, and the third. This is far more important, much more easier. So you can see at the top, this is what we recorded, and you can see there is so much noise, interference, and other things. This is what I analyzed. So this is your quality control. When you look at the bottom window, that tells you what you have analyzed, and that's your good one. Okay. Let's record from another side. I can hear something in the background. See, that's unstable. The waveform keeps changing. The amplitude is low over here, so I'm not going to accept it. I just want to indicate that I heard it. So that's what you do. Always keep listening. Now adjust the position. Again, this is a composite spike. You can see it has got multiple peaks. So that's not a good recording. Again, I adjust the needle. I just don't go like, if you try to do like this, give me more force, now you get nothing. So that's a good position. That's a damaged muscle fiber. It looks like a positive shock wave. You don't accept that for analysis. Again, I adjust my trigger level. So that's good. And let's say I stop over here. So I place the window. This is going to be my first potential. This is going to be my second potential. And you can see there is a slightly higher jitter over here. See, it's 55 microseconds. So this is the way you do 20 sites. Okay. And then you can look for the review. And let's say, what have I done? So I have recorded 3 pairs. Jitter was 41, 30, 55. These are all normal. My median jitter was 41. There is no blocking. So that's the way it's going to be in normal study over here. Okay. Let me show now. So this is the way I like to start, by doing manually understanding how to select a potential, how to look at the quality criteria, etc. There are advanced methods that I recommend once you know the pitfalls, then I recommend automated methods. So here is one such automated method. So see, I'm not doing anything. The machine is automatically triggering on the signals. And I stop. It has automatically analyzed the signals. It has rejected the bad trace, everything. But it's still my responsibility to check over here and see there is a bad trace over here, some large spike. So I get rid of it manually over here. And there is some interface, there is some low amplitude potentials. I get rid of that. Now that's clean over here. Let me go to the next. Okay, the machine is again triggering automatically. So you can see it is detecting 2 peaks over here, coming from here and here. I stop and it gives me the jitter, okay? Again, that's not the best quality. Its rise time is not very nice. So user intervention is always necessary. Let me go to another site. So the machine is trying to detect the peaks automatically. It's updating the jitter over here, 26. This is all normal. This all looks normal to me. I stop. So but to do fully automated analysis, I suggest that you practice with manual things about how you enter. Once you get comfortable, then you can do it. I will do one more site, and then let's see who wants to do the patient, okay? So. See, now it is trying to find, it's measuring this peak also. But is that a good peak? No, it's very rounded. So that's where manual analysis come into picture. So I'm going to say this particular peak, I should not be analyzing it. See, from here to here. So it's up to the user to get rid of things. Manual quality control is very important because it's a very, very sensitive test. So fourth. trying to get something complex. That's a good recording. So I accept it. And again, this is something that is not good. So this is the one I get rid of. Anyway, so you get the idea of how to do the jitter analysis. And again, let me, I can say this is going to be my trigger. This is the one that I want to get rid of. So I choose this. And that's the only one that I keep over here. Strictly speaking, it has a shoulder over here too. If you look carefully, see, it has a little bit of shoulder, but it's way far below. It's not close to the peak. So in that case, I will accept it over here. So in the paper by Professor Stolberg and Sanders, it tells you, when the shoulder is acceptable, and if it is way below, away from the peak, then that's fine. Okay, but if it is closer, then that is not good. Any questions on jitter analysis? And again, as I said, see, I am old, so my tibialis anterior is very easy. Patients are not easy. So start like this. Then you can go to patients and doing recordings. Okay, this looks too easy, right? Myasthenia is much more difficult when you start doing it. Okay.
Very, very, very basic question actually. Is there any activation at all performed by the patient, or is the patient completely relaxed?
No. Patient has to activate.
Okay.
So it's going to be very slight activation. So, look at the level of activation. You cannot even see it. My foot move over here. Okay. See, now this is a complex, but this is a composite spike. Anyway, so I'm going to delete this. That's too much junk. Okay, so what shall we do next? Yes.
So this machine has the peak detection technique.
Yes.
Yeah. So how we change from a peak detection?
Yeah, you
and
saw that
amplitude.
function key at the bottom left, on the bottom right in the previous program.
Yeah.
This is peak only. This program is peak only.
Yeah.
The first program that I showed allows you to go level or peak.
Yeah. Okay.
Yeah.
Okay. Thank you.
Yeah.
My name for my mom.
Yeah. See, this is a new version that I'm working on right now.
Yes.
So, yeah. So this is like somebody who is trained, want full automation, then you can use this. But I still like the first version because I'm in full control of what potential I select, where I place the cursor, and everything.
So problem with tracing signals.
Okay. Anything else? Okay, then you want to do a patient study?
Yes.
Okay, so I don't insert the needle because I'm not a physician. So if you can insert the needle, I will guide the procedure. Okay?
Yes. Maybe Dr. will
Anybody who wants to do it?
Yes.
Okay, so which muscle are we going to do?
Yes. And the elbow. Yeah. Yes. On the right side.
Oh.
Yes.
Okay, so let me just. I will operate the machine and then you can insert the needle and I will guide
Yes.
how to do it. So maybe the patient can sit here. There.
Yes. Sit here.
No, maybe the patient can because this is closed.
Okay. Okay.
So I got wireless mouse. I can sit here and control it.
Sure.
Okay.
Muốn làm không ạ? Yeah. Yeah.
Okay. So what I would suggest, see, this is not a very convenient position.
Yes.
So what I would suggest for learning purposes right now, I would come from here and just stand up and
Yes.
adjust the needle. Usually the patient is lying,
Yes.
but what you can,
The left side.
yeah.
Yep.
So left side.
Yep.
So what you want to do is, can he follow my finger up?
Dạ, nhìn lên ngón tay của thầy.
Yeah. Don't change your head. Head.
Dạ, giữ cái đầu.
Just the eyes. Yeah. That's the way you adjust the activation. Okay. So you can tell him, look at her, or look at the light, or look at the extinguisher, like this.
Yep.
That's it. And then you can see the furrows. So that's where you are going to insert the needle. Okay. Go ahead. Maybe come over here.
The new one. The mới.
Let me start the program. And I start with the basic program, and we are going to do the frontalis, and we are going to the left side. Okay. Okay. So let's put the ground electrode on him. It's over here. Okay.
Cồn.
And you can come from this side and come behind, and then you can insert the needle.
Yeah.
Okay. And now you go like this. Correct. Go ahead.
Nhìn lên xíu. Giữ cái đầu thẳng.
Như cái đầu thẳng,
Cái
anh
đầu
chỉ
thẳng.
cần nhìn lên trần nhà.
Trên trần nhà.
Nhìn cố định lên trần nhà. Cái đèn ở trên trần nhà.
Let him just activate maximum. Let's just see. Let's make sure we are in the muscle. Just ask him to look up.
Nhìn hết mức nè. Nhìn hết mức lên trần nhà.
So we are not recording anything right now. We are not getting signal. Maybe we are not in the muscle as yet. We are too superficial. Let's go deep inside. Okay, now we are coming into the muscle. Okay, move the needle in. See, this is a lot of activation, so let him relax.
Thả lỏng.
Để lỏng lên.
Nhẹ.
Okay, now sharpen the potential. This is still a lot of activity. Relax.
Thả lỏng xuống. Thả lỏng xuống. Nhìn xuống. Đưa lên nhẹ nhẹ không? Nhìn lên nhẹ nhẹ. Thả lỏng nữa. Thả lỏng nữa.
Make the potential bigger. And it is all relax.
Thả lỏng nữa. Nhìn xuống.
Let's see, our signal amplitude is very low. We need to make it 200, 300.
Lên trên xíu. Nhìn lên.
Okay, see, that's the kind of relax.
Thả lỏng xíu. Nhìn
Relax. Good. That's good quality activation. Wonderful. Keep that activation.
Cứ giữ vậy, anh giữ vậy.
That's fantastic. But we got only single. Now you need to adjust the needle position to get 2 spikes. Maybe rotate a little bit. See, there is something over here. Okay, good. Hold it, relax.
Thả lỏng thôi, đừng nhiều hơn.
Relax.
Giống vừa rồi, đừng giữ cái mức vừa rồi.
Relax.
Thả lỏng xuống.
More relax.
Thả lỏng nữa, nhìn xuống. Đừng có nhanh cái chán nhiều quá, anh thả lỏng xíu. Đưa lên từ từ, nhẹ.
Relax and adjust the position of the needle to get sharp signals. Okay, 1 second. Here it is 50 or 60. It's 50 hertz. Main power, okay.
Thì anh nhắm mắt lại, anh mở mắt này, nhắm mắt lại. Rồi giờ mở mắt từ nhẹ lên, đúng rồi.
Okay, that's a good signal. Now we need to get 2 of them. Okay. Hold it there. Stop. See, you have to kind of keep looking at what is happening on the screen. And I could see there were 2 potentials. So I select this one. See, this is, and I keep this window halfway between the peaks. So somewhere here. And I take this window and I put it halfway between the peaks, somewhere there. If you want, you can reduce the duration. It's usually not necessary. So you can see this is a nice tight distribution of intervals. Here are some data points that were thrown out automatically. So that looks good. Now I look over here. See, there is interference here, so I get rid of it. Like this. And that looks clean. Okay. And that jitter is 27. So that's normal. Good. So that was our first recording. Now we go to the next one. Oh, beautiful. Okay, I'm just going to position the second window here. I'm going to stop. Perfect. See, there is a lot of interference over here, but I don't care because that is too far away from my potentials. But this is a very clean recording, nice amplitude, parallel rising edge, very tight interpotential intervals, normal jitter, very normal. Okay, let's go next. Now you can hear the signal. Move the needle. Yep, you can hear the signals in the background. Change the needle position. Okay, relax. That's too much activation. Relax.
Nhắm mắt lại, từ từ anh mở dậy, mở từ từ.
Relax.
Nhẹ. Đúng rồi. Mở ra xíu. Nhẹ.
Relax. And sometimes the patients are going to have difficulty. So let's see what happens. Maybe activate just a little bit. Okay, activate it. Okay, activate a little bit more. Little more. Yeah, there it is. Keep it going. Beautiful. Keep it going. Beautiful. So again, I place the window. This is over here. I choose the first potential. I choose the second potential like this. And maybe there is some interference very close. So I just get rid of this one. And then something over here. So that looks clean. Look at the interpotential, that looks clean. Jitter 20, that's clean. So we have done 3 pairs so far, and all of that is normal. So we can see there is 27. And again, this is a clean recording. Very clean, very clean. This is my summary. I recorded, made 3 recordings. There were no blocking. There was no increase in jitter. 100% were normal. And the median jitter is 20, which is normal. So strictly speaking, we need to do 20 recordings. But that's the principle. So let's just make one more, and then perhaps we can stop. So beautiful. So that's the level of activation that you want. And it's just a needle. Okay, that's good activation. Now adjust the needle position to see if we can get 2. Okay, hold it there. Okay, that's a good single. That's a single. So, but the activation, you can reduce it a little bit. Move the needle to get, because he's looking up. So okay, so sometimes when you don't get any activity, you just ask them to activate a lot, just to make sure your needle is still in the muscle. Beautiful, beautiful. Hold it there, hold it there. Hold it there. Fabulous, fantastic recording, fantastic recording. So I stop, I place my first window, I place my second window, like this. Look at the distribution of intervals, all of that looks nice. Here is some disturbance, so I get rid of those. Beautiful, and that jitter is 25 over here. If you look at the interpotential interval, it's 1, 2, 2.5 milliseconds, which is still acceptable. So that's the way you do the jitter analysis. Okay. Yes. Now that was extremely nice recording. So again, keep in mind slight activation and hunt for the potential rather than just asking them to activate the muscle. And in terms of analysis, you place the window to choose the potential. You look at the distribution of interpotential interval. Maybe you say, there was something happening at the end. There is a trend. You can just click on this and you can say, okay, bring it up to here, kind of a thing. And then look for any interference. So that's that. Thank you so much. I mean, if you want to come closer, you are most welcome. So now we are going to go through EMG waveform recognition. We will do 2 parts. One is the spontaneous activity, and the second part is the volitional activity. So the needle EMG can be done using different needle types. There is a concentric needle, which looks like this, where your active recording surface is at the needle tip, and your cannula serves as a reference. Or in some countries, they use monopolar needle, which is a solid piece of wire which is insulated by Teflon, and then you grind the needle tip to expose the recording surface. Okay? You can use whichever needle type you prefer. Keep in mind that although the principles of analysis are the same, the normal values are different between the two needles. So the needle EMG examination could be divided, for the sake of simplicity, into 4 parts. Insertional activity. This gives us information about the muscle fiber membrane. Okay. Spontaneous activity gives us information about nerve and muscle hyperexcitability. Then we record motor unit potentials. Their waveform gives us information about the motor unit architecture, which means how are the fibers distributed? Is there a change in the number of muscle fibers or the motor unit size? Is there change in the variability of fiber diameter, and so forth? And finally, we ask the patient to increase the force of contraction gradually to reach maximum effort. And that is called interference pattern or recruitment pattern or other terms. So in terms of waveform recognition, this can sometimes be quite tricky. So here is my strategy. So the first thing is that what caused that waveform to appear? Is it because of needle movement? Or is it because the patient activated the muscle? Or is it a spontaneous thing? What is the rhythm? Is it regular? Like tuck, 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 tuck. That's regular. Or is it slightly irregular? Tuck, 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 tuck. Or it is very irregular. Tuck, 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 tuck. Those are very irregular discharge patterns. Then you look at the rate. Is it less than 5 Hertz, 5 to 40 Hertz, or greater than 40 Hertz? You look at the duration of the potential that is occurring. Is it less than 5 milliseconds, or is it more than 5 milliseconds? And you can also look at the amplitude. Is it less than 100 microvolts? Is it 100 to 1,000 or more than 1,000? So there's a logic behind it. Anything that is regular, tuck, 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 it's never normal. Okay? So if you are looking for abnormality, something that is so regular, it has to be abnormal. It could be an artifact, mind you, it doesn't mean pathophysiology, it could be an artifact, but that is definitely not normal EMG activity. Something that is less than 5 Hertz, it's very unlikely that it is volitional, because normal activation of motor unit results in a firing rate of more than 5 Hertz. Similarly, a rate more than 40 Hertz, we usually don't see it. That's abnormal. If you see a duration that is shorter than 5 milliseconds, and if it is spontaneous, it is most likely originating in muscle fiber. If the duration is more than 5 milliseconds, that spontaneous activity is originating in motor units. Low amplitude, less than 100, it is likely to be muscle fiber. 100 to 1,000, it could be muscle fiber or motor unit. And something that is more than 1,000 microvolt is likely to be motor unit. So by using these criteria, you can characterize the spontaneous activity and also localize its origin. And as we did in single fiber, always listen to the sound of the EMG. So let's start this exercise. I'm going to play the signal and we will go through this procedure. Over here, this is 1 second on the top, 1 second per division. This is going to be 10 millisecond per division. So here we go. So what is happening here? We are moving the needle, okay? So this is something that is done by the operator. So what is this? This is insertional activity. Insertional activity does not mean the signals when you are putting the needle in the muscle. It is the signal that is recorded when the needle is in the muscle and you move the needle briskly, okay? So that's the insertional activity. This was in response to the muscle movement. This is mechanical irritation of muscle fibers. See, we can use different types of stimulations. In nerve conduction, we use electrical stimulation. When we do reflexes, we are using mechanical stimulation. We can use magnetic stimulation if we are doing cortical studies. So this is mechanical irritation, and the muscle fibers respond by producing electrical activity. Okay? So there is no pattern to it as such. So long as there is stimulation, you see the signal. As soon as you stop moving the needle, it stops. So it kind of gives you this sound. As soon as you move the needle, it stops immediately, and it has a sharp character because of the action potentials that are being recorded. There is no rhythm or rate involved. It's you define what is going to happen. And if you look at the signals, they may look as a very short potential, like a fibrillation. It may look like a positive sharp wave. Doesn't matter. We are not interested in the signals within the insertional activity. We just want to know how much there is and does it stop immediately. Okay. Now contrast this with this recording. Again, moving the needle briskly. Normal, normal, normal. And now what happened? Although my needle stopped moving, I continue to get persistent activity. Okay? So this is going to be continued activity after the needle stops. This is increased insertional activity. And the increased insertional activity can be in many different forms. It can be like a fibrillation, a positive sharp wave, or a myotonic discharge. All of these can result after needle movement. Okay? It is important to recognize in this signal that insertional activity is not increased at every site. Let's look at this video again. Normal, 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 normal. And the take-home message is that you need to move the needle to many sites to assess insertional activity. You cannot do it at just one site and stop. Okay? Now let's contrast our previous recordings with this. I insert the needle and move it. Do you see any sharp signals? No, you just hear a hiss. And you can see the baseline move when I move the needle. Okay? So, in this case, there is no electrical generator at the end of the needle. the muscle is wasted. It is no longer electrically active. So when you move the needle, you do not get any signals, and this is going to be reduced insertional activity. Now keep in mind that you typically get a fuzzy baseline, but this baseline can also occur due to technical problems. For example, your needle may be in adipose tissue, or it may not be connected properly, and so forth. So here is a summary of insertional activity. This is mechanical stimulation of the nerve, a mechanical stimulation of the muscle. If the insertional activity is normal, that means the membrane is excitable and stable. Increased insertional activity means your membrane is excitable, but it is not stable. It continues to discharge even when stimulation has stopped. And reduce means there is no excitable tissue anymore. Okay. Any question on insertional activity? Okay. Now we go to the spontaneous activity. The needle is the needle is inside the muscle and the patient is relaxed, not making any volitional activity. Okay? So here is something that we can see. The important thing is look at my gain, 50 microvolt per division. Okay? So this activity is very low in amplitude and it fills up the baseline. Okay? And it goes away and sometimes it comes back again. This is miniature end plate potentials. This is spontaneous. Again, as I indicated, look at the gain. It's very tiny, very low in amplitude, fills up the baseline. This is not interference pattern because the patient was not activating the muscle. So this is spontaneous. Its rate and rhythm is variable. It fills up the baseline. And the sound is sometimes described as the seashell sound. Most important thing is low amplitude, fills up the baseline, and spontaneous. This occurs due to spontaneous release of acetylcholine. So our needle is in the end plate area. So we are able to record miniature end plate depolarization. So this is called miniature end plate potential. Let's look at this signal and try to characterize the discharge pattern. Look at these spikes. So, how would you consider the discharge pattern? Regular, irregular, or very irregular? It is very irregular. It goes tat 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 tat. Okay. Slightly irregular will be tuck 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 tuck. It doesn't go up and down as much. And one way you can see that is if you plot the signals. See, this is 100 milliseconds. You can see the potential 3 times. Then you don't see it at all. And then you see it again twice. So that's the way you can see highly irregular discharge pattern. Okay. Let's do some more characterization. High and irregular. It sounds like sputtering. The duration is less than 5 milliseconds. Okay. If you see, this total sweep is 100 milliseconds. So per division, it is 10 milliseconds. It's less than 5 milliseconds. That means this is coming from a muscle fiber. Okay. It has an initially upward deflection. This is characteristic of signals recorded in the end plate area. So these are end plate spikes. Keep in mind that sometimes you can record end plate spikes with initial downward deflection. So the important criteria here is the short duration, less than 5 milliseconds, and a very high and irregular discharge pattern. Also, it is very painful. So the patient will tell you, can you take out the needle? It's hurting me. The important thing when you see such a recording is move your needle, because it will be more comfortable for the patient. Plus, you are in a very excitable area. So you may see spontaneous activity and misinterpret it. So whenever you see end plate spikes, move the needle away. So once again, this is very irregular. You see, you get two very quick discharges, and then you get nothing for a long time. So here is a summary of normal spontaneous activity. Miniature end plate potentials and end plate spikes. Both are generated. The end plate spikes, the generation is neuromuscular junction. The end plate spike is a propagating action potential. And this, I believe, is because of irritation of terminal axon. The important thing is that there is no pathophysiology associated with these signals. Okay. Any questions on this? Yeah. You just move it to a different place. Don't analyze the signals at that site. Yeah, go a little deeper or come superficial, or just take the needle out and insert it somewhere else in the muscle. Yep. Now let's characterize this signal. So, how would you describe this discharge pattern? Regular, slightly irregular, or very irregular? Regular. It sounds like a clockwork. Tuck, 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 tuck. So the rate and rhythm is regular. Okay, what about the duration? This is 10 millisecond per division. So is it more or less than 5 milliseconds? Less than 5 milliseconds. So is it coming from a muscle fiber or motor unit? Muscle fiber. So these are single muscle fiber action potentials occurring in a very regular manner. So what is this? This is going to be a fibrillation potential. The amplitude of the fibrillation potential will depend upon your needle, how close it is to the fiber. It will also depend upon if it is chronic denervation or acute denervation. Okay? One way to look at the regular discharge pattern is to display the signal at a slow time base, like 1 second. This is total 1 second. You can see it is firing 5 times in 1 second. So the firing rate is 5 hertz. And the time between these is almost the same. So that's another way of confirming this is a very regular discharge pattern. Regular, irregular, or very irregular? Regular. So is it normal? No. Anything that is regular is not normal. Okay. Here is, let's characterize the waveform. So the rate and rhythm is regular. Sounds like clockwork. But if you look at the duration, this is 10 millisecond per division. What's the duration of this? Is it less than 5 or more than 5? It's much more than 5. Okay. This is a kind of exception to the rule. This is a recording from a damaged muscle fiber. So this is a single muscle fiber action potential. it has a very sharp initial edge, but then it gets this slow repolarizing phase. This is because of damage to the muscle fiber. This is positive sharp wave. You can see it has a very sharp positive going deflection. Okay? Another way to make sure that your discharge pattern is regular is to raster the waveforms like this. And you can almost connect them by a straight line. You see this? If you peak, if you connect it, it will make a straight line. That indicates that the discharge pattern is regular. The amplitude is variable, again, depending upon your needle position. This is a positive sharp wave. Once again, look at the concept. It is regular. It shifts over here. Here I am showing 10 millisecond per division. So there are 10 divisions. That means each trace is 100 milliseconds. How many traces do I have here? 5. So how much is the total time? 500 milliseconds. How many times do I see the potential in 500 milliseconds? 6. So how many times do I see it in 1000 milliseconds? 12. So that's going to be the firing rate. So that's another way we can estimate the firing rate. Just display the signal for half a second, count the number of times you see the potential, and multiply by 2. Okay? Regular doesn't mean constant. Okay? Regular means firing rate increases gradually or decreases gradually. So it can go tuck, 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 tuck. Okay? Gradual increase and decrease. And when you get that pattern, if you were to connect the potential, it will give you a smooth curve like this. Okay? What do you think about the discharge pattern? Regular, irregular, or very irregular? Okay, if we are not sure, we can pause the traces and we can look at it. You see, it comes from here to here and then it goes over here. It goes from here to here and goes over here. See, if it was regular, you would be able to connect with a straight line. Here, if you connect the potentials, this is going to be a zigzag line. So this is slightly irregular. So this is how voluntary motor unit potentials look like. So when you are looking at motor unit potentials, this is the pattern they produce. They will not produce a regular pattern. So sometimes if you are not sure if this is spontaneous activity or volitional activity that is discharging regularly, just draw the traces like this. Okay? So these were motor unit potentials. Volitional, their rate varies from about 6 to 40 hertz and the rate is slightly irregular. Once again, if you raster them, you see this? This is zigzag. This is irregular firing pattern. Fibrillations and positive sharp waves are one and the same things. Okay? So let's look at this recording. Fibrillation, positive sharp wave, and back to fibrillation. A single muscle fiber action potential has 3 shapes. It can be seen either as an end plate spike, which is initially upward going biphasic. It can be triphasic, which is fibrillation, going down, up, down, and back. Or it can be a positive sharp wave, which is initially going down and biphasic. All three waveforms are manifestations of a single muscle fiber action potential. Okay? So the point I raise this is many times in our reports, we have separate columns for fibrillations and positive shock waves. It's not necessary. They can be in the same section. How do we assess these waveforms? Well, sometimes you get signals like this. This sound is described as rain on tin roof. There are several potentials. All are regular, but at different frequencies. We grade the fibrillations and positive shock waves using two scales. One is a subjective scale, 0, 1 plus, 2 plus, 3 plus. Notice we have 0 and 1 plus. That means if you saw only one fibrillation or one positive shock wave, it has to be reported as 0. Okay? We always allow for very, very mild slight abnormality. Just like in jitter analysis, we allow 2 recordings out of 20 to be abnormal. Similarly, we allow 1 site out of 10 in spontaneous activity to be abnormal. And we still call it a normal muscle. Okay? That's the principle of analysis in all of the signals that we record in the EMG lab. So here is the pathophysiology. This is a normal muscle fiber. It has got an end plate, it has got an axon, and this does not generate fibrillations and positive shock waves. If we have denervation, now we no longer have the axon, this muscle fiber will produce spontaneous activity. Therefore, many people call it denervation potential. But you can also get this activity in patients with myopathy. So if we had necrosis over here, we have a muscle fiber that is not innervated. And that is going to produce fibrillations and positive shock waves. So I discourage the use of term denervation potential. Just indicate there were fibrillations and then suggest pathophysiology. It's denervation or inflammatory process causing necrosis. Okay, let's continue with our signals. So what's the firing rate over here? It's variable, but it's kind of monotonic. Wow. So the rate goes up and then it goes down. If you look at the amplitude, it also goes up and down. So this is what is called waxing and waning. So the rate increases and comes down. The amplitude goes up and comes down. Again, this is triggered by needle movement. Rate and rhythm is waxing and waning. And it has been described as dive bomber. Professor Kimura corrected that. He said, no, dive bomber doesn't sound like that. He called it revving a motorcycle. Okay? So he used to call it the Kawasaki discharge rather than a dive bomber. It has a duration of less than 5 milliseconds. So it is coming from a muscle fiber. And it can be, again, in the form of a fibrillation, positive shock wave, or an EP spike. Okay, it doesn't matter. This is typically seen in myotonic dystrophy, but also in other conditions, for example, acid maltase deficiency and so forth. Spontaneous activity is often not characteristic of any single disease. Okay? You can see it in many different conditions. So that was a myotonic discharge. Again, listen to its sound. Waxing and waning. Okay. Now compare it against this. This is a very regular sound. Okay. This is when you use amplitude trigger, you can see it has a fixed configuration which keeps repeating. Okay, so you can trigger on it, you can superimpose it. It's exactly the same pattern that gets repeated over and over. And the firing rate is very regular. You can see it at the top. If you look at the individual components, they have short duration. So this is a group discharge of several muscle fibers. And this is what is called a complex repetitive discharge. It has a mechanical sound because of its regular firing pattern. And it usually reflects a group of denervated muscle fibers, typically seen in chronic neuropathies. And the basis for this discharge is ephaptic transmission. I will explain that in a second. So how does this discharge generate? Well, here is the idea. Here are 4 denervated muscle fibers. And there are hotspots between these fibers. So the action potential can go from one fiber to another at the hotspot. Okay? Usually action potential, muscle fiber action potential is generated from neuromuscular transmission. Now we are talking about transmission of action potential from one muscle fiber to another. This is called ephaptic. You can get ephaptic transmission between nerves also, nerve fibers. Ephaptic means it is same type of cell that is activating. So here are 4 denervated muscle fibers, and number 1 produces a fibrillation. It reaches hotspot, it gives it to the next fiber. It gives it to the next fiber. So that's the way the action potential spreads from one muscle fiber to next. How does it sustain? Well, let's look at the muscle fibers in a cross section. So this is like WhatsApp. So muscle fiber 1 wants to send a message on WhatsApp. It goes to number 2. 2 sends it to 3. 3 sends it to 4. 4 sends it to 5. And then 5 sends it back to number 1. And so number 1 thinks, oh, that's a good, let me send it again. So now you get this process repeating over and over. So that's the way a complex repetitive discharge is produced. What's the rate? High, low? Is it regular, irregular? Low and irregular. Amplitude? High. Duration? Is it short? Let's see. This is 20 millisecond per division. So from here to here, it's about 15. Okay? So if the duration is more than 5, most likely it's a motor unit. Say a motor unit discharging spontaneously at irregular rate. What is it? This is fasciculation potential. Okay? So the fasciculation potential is a spontaneous discharge of the motor unit. It can originate in the nerve or it can originate in the motor neuron. Keep in mind, this can be seen in healthy subjects also. So if you exercise a lot, let's say you went for a jog, you come back, take shower, sit down, and now you see your gastroc fasciculating. Or if you have too much coffee, now you get fasciculations. So fasciculations can be seen in healthy subjects, but their importance is mainly in patients with motor neuron disease. In patients with motor neuron disease, this is one of the things that they will often indicate. And now when you also see fibrillations and positive shock waves, that's not a good sign. But if you see fasciculations by themselves with no other spontaneous activity, you will call them as benign fasciculations. If you have complex fasciculations, then that would indicate that these are reinnervated motor units and can be used for the diagnosis of motor neuron disease. Describe the sound. Is it low frequency or high frequency or both? Yeah, but then it stops. So this is actually a burst pattern. Within the burst, it discharges very fast. And then it stops, and then it starts again, and then it stops. So once again, these are high amplitude, long duration, so these are motor unit potentials. And this is described as marching, soldiers marching, which I absolutely disagree. When soldiers march, they are very, very precise. So many times we have bad terms in our description. So these are burst-like discharges of motor unit potential. Sometimes it can be multiple potentials that discharge in a group manner. Those are called group fasciculations. And again, this is probably ephaptic transmission in the nerves that causes grouped fasciculations. They are typically seen in radiation plexopathy and polyradiculopathy. Listen to this signal in the middle part. I will tell you when to listen. Now, that was the sound. 1 second. Did you hear that sound? It was okay. That's the way it's called. The sound is described as ping sound. Okay. Again, these are motor unit potentials. They are discharging at a very high rate, 100 hertz or more, and they also demonstrate a drop in amplitude. This is what is called a neuromyotonic discharge. I don't like the term myo. I like to call it neurotonic. These are motor unit potentials, not muscle fibers. Okay? Yes, your question. Yeah. Yeah. So, again, it has characteristics similar to a myotonic discharge. That's why it shows waxing and waning. The rate is high, 100 hertz or more. It has a ping sound. The duration is more than 5 milliseconds, indicating it is a motor unit potential. And this is hyperexcitability. This is something that you don't see often, but you are most likely to see it in Isaac syndrome, hyperexcitability conditions. Okay? So these are the most commonly recognized forms of spontaneous activity. Okay? Now, there are many other things that can happen. So let's look at this. So it has a burst-like pattern, it has got a ping-like pattern. All kinds of things are happening. And if I were to trigger this signal, you see there is a motor unit potential and there is a burst of activity. So we called it motor unit induced neurotonic discharge. So we call it MINT because it is triggered with a volitional motor unit potential, and then it is followed by its discharge at very high frequency. So this is what we call the MINT. And there are many other potentials that occur for which we don't have a common description. My point is that if you fail to characterize a spontaneous activity, don't worry. Just confirm that it is spontaneous and try to identify, is it coming from the nerve or is it coming from the muscle? Okay. Let's see, what's this? This is at rest. And now what happened here? It filled up the screen. High amplitude, long duration. So this is EMG activity. Any idea what this was? The patient was resting. This was a cramp. And cramps will occur when you are recording. Thing is that you just try to get rid of the cramp because it can be, cramp itself is painful. Then you have needle, so that makes it even more painful. Okay. Interesting thing in the cramp, you can see here is a motor unit potential. You see it 4 times over here, 4 times, 5 times. It is discharging at a very, very high rate, about 50 hertz. This is not typical. I mean, when we activate the muscle, we don't activate a single motor unit like this. So I think that's what is different about cramps. So it is spontaneous, rate and rhythm very high and variable. Duration is more than 5, so it's a motor unit potential. Many motor units discharging in a non-coordinated manner. So I think that's what causes pain. Cramp. So these are the this is the summary of different types of spontaneous activity. At the top, you can see those that are generated at the level of muscle fiber. So you got fibrillations, positive shock waves, complex repetitive discharge, myotonic discharge. And then here are the activities that are generated at the motor unit level. So the origin is in the nerve or in the motor neuron. And they indicate hyperexcitability of nerve and neuron over here. Now, let's look at, characterize this. How would you describe this pattern, the sound? It was kind of regular, but it was still like, it was more like a burst pattern. And you can see it very easily on the top trace. Any idea what this was? Tremor, wonderful, okay? That is something you can see it when you are studying the muscle. So this is spontaneous activity, this is not volitional. This was tremor, and you can characterize it. This is total 1 second. So 1, 2, 3, 4, 5, 6, 7. It happened 7 times, so that means the tremor frequency is 7 hertz. This is typically the essential tremor or physiologic tremor and so forth. Okay. So it's a burst-like pattern, motor unit potentials, and I described it as a multi-cell kind of a sound. Okay. Okay. There is no sound. What do you think this is? Is it regular, irregular? So, what do you think this is? Is it voluntary? If it is regular, it cannot be voluntary. So this is spontaneous. Spontaneous, regular, And what's the best match that you can find to this signal? It kind of looks like fibrillation. But I will play it again. Now put your hand on your heart and try to follow it. Tuck, 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 tuck. It's the pacemaker. Okay? So it's a pacemaker artifact. So it's important to make sure you take proper history, because otherwise you will stick in the muscle and you look at this as, oh, he has got denervation. No, this was a pacemaker. Okay? Pacemaker artifact. And this is from my friend, Professor David, William David from Harvard Medical School. He sent me this video and tried to characterize the sound. Okay? First of all, is this normal or abnormal? Abnormal. You never hear volitional EMG like this. Okay? So something that is this bizarre. Now, how would you describe the sound? Was it regular, irregular, or burst? Brr, 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 brr. So they're a burst-like pattern. So what produces a burst-like pattern? What signal? Myochymic discharge. Okay? And now, is there a single burst or multiple bursts in it, or multiple patterns? There are many myochymic discharges. So this is the way you listen to the signal and then try to decompose it. What's the pattern? Okay, that sounds like burst, so that could be myokymia. Now there are multiple myokymia, so that's why that is giving it a very interesting sound. So we think, this was our thinking, that sounds like frogs. When you are near the river or near a pond at night, you will hear a sound like this. So we call it, instead of multiple, we call it a frog discharge. But these are myokhymias as such. Okay? So the sound reflects the waveform and discharge pattern. That's why sound is very, very important. Volitional activity is always greater than 5 Hertz. So anything that is less than 5 Hertz is most likely spontaneous. Volitional activity is also modulated by activation. So if you're not sure if it is spontaneous or volitional, ask the subject to relax or contract a little bit more. Regular pattern indicates spontaneous activity. Keep in mind, spontaneous activity can also have irregular discharge pattern. But if it is something is regular, it is spontaneous and abnormal. And some artifacts can mimic abnormal spontaneous activity. Like the pacemaker artifact may look like a fibrillation. Okay? So, any questions on spontaneous activity? In that case, we move to the last topic for this morning. So we looked at the first part, which was the insertional activity, the spontaneous activity. Now we ask the patient to give a slight contraction. And then we also look at higher contraction. So volitional activity is studied at low, mid, and various force levels. Typically, we do the needle EMG examination subjectively. We just look at the traces on the screen, we listen to the sound, and then we quickly try to make a guess about whether it is volitional, spontaneous, high amplitude, low amplitude, etc. One can also do these things quantitatively. The problem with quantitative is that you record from signals from multiple sites, you make measurements, you compare with reference values. It is usually considered time consuming. And there is also a paucity of reference values. So how do you use reference quantitative analysis? What I like to use is something called objective and interactive. That means you use the principles of quantitative analysis during subjective assessment. Measure amplitude, measure rate, document abnormalities. Yeah. So let's start with anatomic basis for motor unit potential analysis. Why do we want to analyze MUPs? So here is a schematic of a motor unit. There is a motor neuron over here, axon. When it reaches the muscle, it divides into several branches. These are the end plates, and this is our recording surface over here. When the nerve action potential comes, it goes through the terminal branches, and as we just studied in the previous talk, it gets transmitted across to the muscle fiber. That's your neuromuscular transmission. The muscle fiber generates an action potential which goes to the two tendons. So every time the motor neuron discharges, all muscle fibers respond by producing an action potential, which is recorded in the extracellular space. So here are the action potentials shown schematically. See, this is fiber 1, that's the action potential. Fiber 2, that's the action potential, and so on. There are three important things to recognize in this schematic. First of all, the shape of the action potential is not monophasic, relatively monophasic. Like in intracellular, this is your resting, depolarization, and you come back. It's relatively monophasic. But what we are recording is not intracellular. We are recording in extracellular space. So that's why the waveform is triphasic. As the action potential approaches the electrode, you get the downward deflection. When it is in front of the electrode, you get the main spike. And as it goes away, you get the terminal positive phase. Usually, these are triphasic potentials. Number 2, the amplitude for each action potential is different. A muscle fiber that is close to the needle, this one, will be recorded with a high amplitude. A muscle fiber that is far away will have low amplitude. And finally, these action potentials are not synchronous. Some appear early, some appear late. There is a temporal dispersion. See, up to this point, we have a single action potential. Now when it starts going through the terminal branches, each branch is of different length. The diameter of these branches may be different. That means that the action potential propagation velocity in these branches are different. As a result, the nerve action potential appears at the presynaptic terminal at different times. Then we have the time for neuromuscular transmission, which itself can be different in different end plates. Once the action potential is produced, it has to reach the muscle fiber. This distance can be different in different muscle fibers. And finally, the fibers are of different diameter. Larger diameter fibers conduct faster compared to smaller. So you can see there is a temporal dispersion produced in the nerve portion of the motor unit, and there is a temporal dispersion produced in the muscle part of the motor unit. What we record is the sum of all of these action potentials. So the motor unit potential is a sum of action potentials of all fibers in the motor unit. And we make the hypothesis that the shape of the potential will change if there is a change in motor unit architecture. That is, the number of fibers, the variability of fiber diameters, grouping of muscle fibers, all of that will affect the motor unit potential. That is our hypothesis, and that's the reason we analyze motor unit potentials. So here is a schematic. This is a normal motor unit. As we studied in single fiber, the muscle fibers are scattered across the territory. They do not show any tendency to form groups. What happens in a primary muscle disease? You get loss of muscle fibers. You get atrophy of muscle fiber. You can get hypertrophy of muscle fibers. And sometimes the muscle fibers become very large and then split into several branches. So it's like an octopus. You got a big head and then you got a lot of tentacles. So in the cross section, it looks like this. You get a focal grouping with increased variability of fiber diameter. So that's the way the motor unit changes in primary muscle disease. If you had partial motor unit loss, here is what happens. These are two motor units in a normal state. Now let's consider that the second motor unit died. Maybe there was axonopathy, maybe it was motor neuron disease. The net effect is we have denervated muscle fibers. The denervated muscle fibers send out a distress signal. Please innervate me. So the surviving muscle fibers or the surviving motor units produce collateral nerve axon branches. And these branches are very, very small. Okay? So for example, the red motor unit can produce a branch and innervate this muscle fiber. But the red motor unit is too far away from this fiber. So the red motor unit cannot reinnervate this fiber. Reinnervation can occur only in the area where the motor unit territories overlap. Okay? So that's why these muscle fibers are now captured by the red motor unit, and these by the purple, and these by the green. You will notice that we have reduced number of motor units, but each motor unit is big. That means it has more fibers. Furthermore, the fibers are densely packed. You have increased fiber density. Now, this can be quite successful. So that's the reason patients with radiculopathy or other nerve lesions, they can be initially weak, but they can recover normal strength or nearly normal strength. Okay? But they still have reduced number of motor units. Now, towards later age, what can happen is that this motor unit, the red motor unit, can die. Normal aging process. But notice that this is a very densely packed motor unit. There is nothing else that is overlapping in its territory. That means this motor unit cannot be reinnervated. And so the weakness is going to continue. So this is the explanation, for example, for the late weakness in patients with polio. Initially, they had loss of motor units. They had successful reinnervation, so they recovered majority of their strength. But now when you lose a large reinnervated motor unit, it cannot be reinnervated again. So you have to live with it. Okay. So the idea is that these are the changes in motor unit architecture, and we hope we can study them from motor unit potential. So we can record motor unit potentials. There are many methods. A simple method is to just freeze the traces on the screen, and we see whether a particular waveform repeats or not. If you see a waveform 3 times, it's a motor unit potential. Okay? So how many waveforms do you see repeating in this example? Three. See, here, here, here. This is here, here, here. This is here, here, here. If you see it 3 times, then you consider it a motor unit potential. Okay? We can measure the amplitude. So this is 200 microvolts per division. So that's about 400 microvolts. If you look at phases, this is going 1 below, up and down. So that has 3 phases. Anything that has got 4 or less phases is simple. 5 or more phases is considered polyphasic. Okay. We can also measure the duration. So this is about 5 to 7 milliseconds. Duration can be difficult. See, you have interference in the baseline. So you really need something clean for measuring duration. In other words, you have to use very low force of contraction. We can also make measurements using vertical cursors, etc. But you can simply use the grid to make estimations. Now, are these polyphasic potentials? First of all, do you see it repeat? No. So you cannot analyze this. This is not polyphasic potentials. See, these were the 3 different potentials that they just happened to superimpose to give a polyphasic waveform. So this is one of the most common mistakes in EMG analysis, that you look at superimposition and misinterpret as polyphasic waveform. Polyphasic waveforms produce a different sound compared to a single sound. It's a multisyllabic sound, prop, 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 versus a single motor unit would go tuck, 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 tuck. So we can measure amplitude, phases, duration, etc. We can also trigger on motor unit potentials. So this is free running. We can set up what is known as a trigger, and now you can analyze a single motor unit potential waveform. You superimpose it, and this is useful to look at the so-called stability of the waveform. See, every time the motor unit discharges, it has the same shape. So this is what is called a stable motor unit action potential. Okay? This can also be useful to study linked components or satellite potentials. Or we can use automated methods. We insert the needle, ask for slight contraction, record for about 10 seconds, stop, and the computer has identified 4 different motor unit potentials. This is what is called multi-motor unit analysis. So all kinds of methods are available for our review. So this is how motor unit potentials look like in a normal muscle. They are by and large triphasic, and their individual duration is typically about 5 to 15 milliseconds. The amplitude is about 200 to 2000 microvolts, and so forth. Myopathy is very challenging because you can get simple potentials of short duration. You can get simple potentials of high amplitude. You can get linked potentials. You can get polyphasic potentials with long duration. So that's what makes motor unit potential analysis very difficult in myopathy. In neurogenic, you tend to get high amplitude potentials with long duration. Okay? So here is the correlation between the motor unit potential waveforms. I will not go through the details. Amplitude reflects the number and size of fibers near the needle tip. Phases and turns the temporal dispersion of action potentials within 1 millimeter. Duration, number of fibers within 2.5 millimeter. Okay? So different sections. So amplitude and area, why would it increase? Because you had increased density of muscle fibers. This will happen from reinnervation. But if you had hypertrophy, you can also get high amplitude. So slightly increased amplitude can be seen even in patients with myopathy. Reduced amplitude is going to be due to loss of muscle fibers and atrophy. Why would duration increase? Because there are more fibers in the motor unit. Again, that's going to be because of reinnervation. You could also have increased variability of fiber diameter. And that's also going to give you long duration potential. So that's why Professor Buchthal indicated that when you are looking at duration in patients with myopathy, do not analyze polyphasic potentials. Analyze only the simple potentials. Let's look at our example. Analyze this. That's a short duration. That's a short duration. That's a long duration potential, but that's polyphasic. It is long duration, not because of reinnervation, but because of increased variability of fiber diameter. Okay? So we don't use them in duration analysis. And duration will be reduced due to loss of muscle fibers. You can have complex waveforms, polyphasic, because of increased variability of fiber diameter, so that's myopathy. Or you can have slow conduction in terminal axon branches, which is neuropathy. So polyphasic potentials are non-specific. You can see them in myopathy and you can see them in neuropathy. And unstable waveforms are abnormal neuromuscular transmission. The waveform changes from one discharge to next because of increased jitter. So let's look at these examples. So here is a motor unit with myopathy. Here is my electrode. So what do I see over here? There is a loss of muscle fiber, but normal fiber diameter. So this produces a potential with short, simple waveform. It is biphasic, short duration. This is the classic myopathic potential. Short duration, low amplitude, simple. If my electrode was over here, now it's going to see increased variability of fiber diameter. So that's going to produce a potential that is polyphasic and long duration. I trigger on it. This total is 30 milliseconds. And if I were to superimpose these discharges, you can see the waveform is very stable. It's polyphasic and long duration, reflecting increased fiber diameter variability. If my muscle fiber was next to a hypertrophic muscle fiber, you are going to get high amplitude in myopathy. My gain is 1 millivolt per division. Look at this. It's 3 millivolt in amplitude, but it's a very short duration waveform. So short duration is specific of myopathy. Long duration is neuropathy. Polyphasic is non-specific. Unstable is non-specific. Okay? If we look at neurogenic, listen to the sound. It is very dull, indicating long duration. If we trigger on it, we can see satellite potential. Look at the peak. It is changing. That means it's an unstable potential. Okay? So this is ongoing renervation in a patient with neuropathy. Now let's quickly look at the interference pattern. We increase the force from slight, and now this is moderate effort and maximum effort. You will notice that there is an increase in the amplitude, and also the baseline becomes completely obscured with EMG activity. So this is normal. At maximum effort, full pattern, that means you cannot see the baseline, and normal amplitude. In myopathy, at full effort, you can see full pattern, baseline is completely obscured, but the amplitude is low. And the signals will often have a high-pitched sound. If you look at neurogenic, at maximum effort, the pattern is not full. You can still see the baseline and discrete spikes. This is what is called the picket fence pattern. And the amplitude may also be increased. Okay? So let's look at the signals. This is normal. Slight effort. Increase the force, the baseline becomes obscured, and the amplitude increases. That's normal pattern. Okay? Okay. Now, let's compare it with neuropathy. Listen to the sound. It's dull. Increase the force, and you can still see the baseline. This is reduced pattern and high amplitude. Okay? Now let's look at myopathy. Even at slight effort, the pattern becomes full. See, even at low effort, it is full. And when you increase the force, the amplitude doesn't increase much. Increases only a little bit. And the signal had a low pitch sound. So that's the way we differentiate EMG patterns in neuropathy and myopathy. So there are techniques which are called turns and amplitude, which will allow you to document this pattern. So what we make is look at the number of peaks in the signal. So, the signal is going like this. How many peaks do you have? And what is the average amplitude between the peaks? Number of peaks is on the x-axis. Amplitude is on the y-axis. Slight effort. And you make a data point. Now you increase the force, second data point. Increase the force, third. And now you repeat this. This is what is called the turns and amplitude method of analysis. Okay? This is the so-called normal cloud. So if the muscle is normal, everything falls inside this boundary. This is how it looks in neuropathy. In neuropathy, we have few motor units, few spikes, and they are large. So you are going to get data points in this area. Slight effort. See, it's near the upper border. Moderate effort. Upper border. Now we go to maximum. And now it is outside. So just like in single fiber, as soon as you see 3 data points outside the cloud, you call the muscle abnormal. Okay? In myopathy, we get opposite pattern. Now we have a lot of spikes, but they are low in amplitude. You see it's on the lower border, lower border. See, this is the myopathic pattern. So this is the way we can do quantitative analysis of the EMG interference pattern. Now, we can also perform what is known as recruitment analysis. It's a fascinating concept. You start at slight effort. You see 1 motor unit. Increase the force, you get the second motor unit. Increase the force, you get the third motor unit. And you relax. Okay. And if you analyze the firing pattern, this is what you see. The first motor unit starts here, firing rate goes up, and then you recruit second motor unit. And then the firing rate goes up, and then you recruit the third motor unit, and so forth over here. So we can measure what is known as the recruitment frequency. That's the firing rate of the first motor unit when the second one comes in. We can measure the recruitment ratio, which is how many motor units and what's the firing rate, and so on and so forth. It's an interesting concept. Keep in mind that these are the normal limits. And this is the way it has been described, that the first motor unit, it starts discharging at 5 hertz. You increase the force, it becomes 10 hertz, and then the second one is activated. And then this is 15, the second motor unit has 10, and then the third one comes in. So this is the basis for the so-called recruitment ratio. It's a simple model, but in reality, our muscle doesn't work that way. Actually, this is what happens. So this is normal muscle, and you can see we have got many motor units that are firing at the same rate, roughly. See, here all of them are very distinct, but in practical recordings, we don't see it. We don't see 5, 10, 15, 20 pattern at all. Okay? So actually what happens is that when you increase the force, a motor unit is recruited, and then it kind of idles. So it starts at about 5. You increase the force, it will go to 10. At 5, it is irregular. At 10, it is like tuck, 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 tuck. You increase the force and it goes a little faster, tuck, 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 but it is still less than 15 hertz. And that's the way you recruit all the motor units at slight force of contraction. And only when you need high force, that's when the firing rate goes above 15. Okay? So again, this is slight effort. Look at this now. If you look at the firing rate of the motor units, This is 20 or 30 hertz. This is seen only at moderate to high effort. If you can see a firing rate of 15 hertz or more, by visual assessment, the muscle is abnormal. Because in a normal muscle, you will never be able to see a rate of 20 hertz. Okay? So that's the way we can define reduced recruitment. So let's look at this signal. You see it twice on each sweep. The rate is 20 hertz. There is no other motor unit. This is reduced recruitment. In myopathy, it's opposite. Even at slight effort, you fill up the baseline. And these are all discharging at normal rate, about 8 to 12 hertz. This is increased or early recruitment. So let's look at some final examples. What do you think about this? Slight effort. Does that look neuropathy or myopathy? Myopathy. It filled up the baseline, right? Let's increase the force. What was that? All of a sudden, you got very high amplitude, but they were short duration. This is inclusion body myositis that have hypertrophy of muscle fibers. So keep in mind, amplitude is very easy to measure, but it is very deceiving sometimes. Duration is the most important parameter. When you are doing differential diagnosis, never study a very weak muscle. If the muscle is extremely weak, you can get conflicting patterns. Always use a moderately weak muscle for analysis. So in summary, motor unit potentials provide complementary information about motor unit reorganization. Study moderately weak muscles for higher sensitivity and specificity. Very weak muscles may show mixed patterns that are difficult to interpret. Quantitative analysis is not time consuming. There are so many methods that are available. Objective interactive approach is very easy for documentation. For example, use an amplitude trigger to look at the stability. Use multi-motor unit analysis to capture abnormal motor unit potential waveforms. Use turns amplitude analysis to show the pattern of data points. Look at moderate firing rate at moderate effort. If you can see a firing rate of 15 hertz by visual assessment, that's an abnormal muscle. Okay? So that, in summary, is a quick review of volitional EMG activity. Any questions? Okay, then at least as far as I'm concerned, I am finished. So, but if you have any other questions, I will be more than happy to answer them. If you have any other techniques that you want to learn about, that's okay too.
Should we move to a practical session?
For?
Practical session for EMG.
Okay. Yeah, I mean, we can do a practical session on EMG. That's perfectly all right.